On behalf of the Cultural Diversity Day Committee, once again for joining us. I am very pleased to be introducing Dr. Marc Fishman, who's going to be our grand round speaker today. Dr. Fishman is an addiction psychiatrist and leads the Maryland Treatment Center at Mount Manor, a regional behavioral health care provider, which offers programs for residential and outpatient substance use disorder and co-occurring treatment for youth and adults. He's a member of the psychiatry faculty at Johns Hopkins University School of Medicine. His academic and research work has focused on addictions pharmacotherapy, models of care for youth, particularly with opiate use disorder, and treatment placement and matching strategies. Dr. Fishman served as a co-editor for the most recent editions of the American Society of Addiction Medicine Criteria for the Treatment of Substance-Related Disorders. He served as a past president from 2010 to 2012 of the DC Maryland Society of Addiction Medicine and is a current member of its boards. Dr. Fishman, thank you for being here, and the floor is yours now.
Oh, thanks so much. And it's a great treat and honor to be with you guys this afternoon. I'm going to be talking about a clinical approach to family engagement and try to walk you through some of the lessons that I and my colleagues have been at least trying to learn about the power and impact and potential for broadening our scope, if you will, from a narrower focus of just the patient in front of us, which of course still remains critical, broadening that to see what we can learn and how we can help by leveraging the influence and engagement of families. These are my disclosures. In particular, note that I've been a consultant for which makes extended zone involved in one of the studies I'm going to show. I don't think that biases me, but you guys will have to be the judge. And how we'll organize today's conversation, I'll describe some barriers to family engagement because I think it's important to remember that we don't always do as good a job as I think we might or ought to, and talk about why that is maybe. Rationale for engaging families, and then talk about some of the clinical basics, the how-to family engagement, and then spend the second half of the talk drilling down to a focus on young people in which family engagement is a particular component of an intervention that we've been working on for young adults with OUD, and showing you kind of an example of how we've tried to bring family engagement to bear on that target population, and show you some data supporting some of our pilot work with that intervention. All right, so let's get started with talking scope of the problem. What are some of the barriers? And one of the issues, not just for young people, but for people across is when they present for treatment in crisis for an SUD, they may have a very normative sense of the family as having an exaggerated and sometimes even punitive role in regards to their treatment, seeing family members, parents as intrusive, seeing them as overly restrictive and blaming, young people in particular with one foot in childhood and one foot in adulthood, wanting to see themselves as independent, resenting the notion of dependence on family. I'm all grown up, it's none of my, but the same applies perhaps for a partner, a spouse. This is my problem, not my wife's, not my husband's problem. Why would you involve them? I think from the clinician's perspective, as we'll talk about more, this is not easy. Most clinicians don't have the experience, perhaps the competence, perhaps the comfort level of involving families as much as they ought to. Our field has focused a great deal, and understandably and reasonably so, on the importance of internal transformation. But that's not the only way that behavior change happens. Lots of behavior change happens because of external leverage. And so one of the problems, I think, has been that we haven't necessarily focused enough on how families can contribute to that kind of external leverage over and above and in addition to the internalization of motivation. But remember, that might come at a later point. Uh, when you talk about families in traditional SUD treatment, you hear a lot of this word enabling. What is it that families are doing that reinforce the behavior or make things worse? That leads both families and clinicians perhaps to not want to include families as much. And we'll talk a little bit about that. And then a big issue, I think, is the barrier of our, what I think of as over-rigid concern with confidentiality. And don't get me wrong, confidentiality is the cornerstone of what we do in trying to allow people appropriate access to private and confidential services. But I think a rigidity of limiting communication where families and other concerned others might be useful in broadening the communication scope prevents people from doing that and thinking about how to finesse the issue of confidentiality barriers. And then I don't have to tell you guys about the problems of the stigma of SUD, right? In any other illness in the house of medicine, if your loved one has a difficulty, has problem negotiating the medical care system, you bring your family member in, you sit in the doctor's office with them, you help them figure out what's a good treatment option, you help remind Granny to take her medicine if she can't remember. And the stigma against substance use and substance use disorders and accessing services makes it so that's somehow very different with substance use in the shameful shadows, and that also being a considerable barrier, both from a provider point of view, from a patient point of view, and a family point of view, as a historical to family engagement. Just to walk through these three different perspectives, I'll kind of give you cartoons of a patient perspective, a family perspective, and a clinician perspective. But these are some of the things you'll hear patients say. Oh, they don't understand what I'm going through. This is my treatment. It's none of their business. My wife's, my husband's, my parents, my kids. Listen, even if they did understand, they don't know how to respond. They just see, they criticize me. They're angry. What's the point? I don't want them involved. And besides, they just assume I'm guilty. I'm always wrong until proven otherwise. They never think the positive. They always think the negative. I'm not a baby. I don't want to be treated like a child. I'm a grown man. I'm a grown woman. How dare they presume me what to do? And by the way, I know my rights. You can't talk to my family. I'm a lawyer up on y'all. No, I'm exaggerating, but you probably have heard all of those things before. And what about the parents? What about the families? Listen, I'm not allowed to be part of this conversation. I'm boxed out of my loved one's treatment and have no input. By the way, you've all kind of heard parents complain or families complain. I know my love is receiving services there. I just dropped them off for counseling. They're living in my house, paying for the Dern treatment. Hey, can I talk to a counselor about how things are going? I'm sorry, we can neither confirm nor deny that a person by that name is receiving services. Please call between the hours, I'm again exaggerating, but maybe not by much. I can't get any info. And when treatment professionals do deign to talk to me, they tell me things like, I need to let go. It's not in my power to change someone else. Stop enabling. You must use tough love. And by the way, when we use that term enabling, what is it that is here? Not necessarily saying it's what we intend, but when we use that term, what they hear, it's your fault. You're making it worse. You're a bad wife. You're a bad partner. You're a bad husband. You're a bad parent. Not saying we mean that, but I'll tell you, that's what they hear. They hear you must respect boundaries. Well, what does that mean? You should stop. What do you mean I should stop rescuing them? They could die. I'm not supposed to pick them up at the middle of the night when they call park when they're down and out in withdrawal. Of course I'm going to pick them up. Don't tell me to stop rescuing. So these are some of those perspectives. And then what about from the clinician's perspective? Well, the patient is being dishonest, sneaky, and devious. the family being overbearing, punitive, and ineffective. I can't ever bridge that gap. And besides, the regulation for confidentiality ties my hands. I'm not allowed to talk to them anyway. So leave me alone with all that. Again, these are exaggerations perhaps, but they give you a flavor of what I think of as some of these historical barriers. So given that, why would we try to overcome those barriers? What's the utility? What's the rationale? Why focus on families? Well, let me just give you a quick case vignette that kind of pitches some of the conflicts and the impasses. This happens to be a young adult, but we could draw the same kind of picture about an lifespan. A 25-year-old young man lives with his parents, a commuter college student, is a daily cannabis user, and has just recently transitioned to early initiation of non-medical prescription opioids, and the parents have found out, and they're concerned about his declining academic performance, and he's in trouble and on the verge of getting kicked out of school, etc. And the kid says, well, there's nothing wrong with weed. They're a child. They're always screaming at me. I'd just as soon live on the street. There's no point with this. And the parents say, he doesn't get it. If he does these things, he'll never get anywhere. He lies and he steals. This isn't the way we raised him. So the clinician, perhaps wiser than most, says, let process the discussion and negotiation. You can set some rewards and consequences for behavior. The young man, you can set for rewards and negotiate with your parents. And we're going to talk a bunch about that kind of strategy as an approach to engaging families as we go on. And the parents, though, are on the verge, the precipice. We don't have time for this. We can't stop driving him. If we did, then he wouldn't go to school. We can't set limits by refusing to, because he says he'll run. What's the point? He doesn't listen. There's nothing we can do. This will never get better. We might as well just throw him out. So quick escalation to the nuclear option. And the patient, I don't want to meet with them. They don't need to know my business. They'll never give me whatever it is you're suggesting as a reward unless I'm perfect, and I can never be perfect. What's the point? They're just going to throw me out anyway. I might as well just leave. Again, quick escalation to nuclear option. And they're so embattled by the time they present for crisis-driven care, which is often how things go at the beginning, that on their own, they have no way of making any progress. So if we could contribute to progress, could bridge that gap. The rationale would be that we could bring them away from the precipice and perhaps make progress with engagement towards treatment goals. And thinking about that balance, on the one hand, families are desperate for immediate change. They say they've tried everything. We've spent our money bailing them out, repairing the debt to happen, giving them money that just disappears. I'm done. We're finished, kicking them out of the house. Or, on the other hand, the don't ask, don't tell. I don't want to know about it because no matter what I do, my child, my loved one, my spouse is going to continue to use everything. I just don't want to know about it. And what, of course, you might suppose is that neither of those extremes are effective. It's just that they're up to their ears in alligators by the time they've gotten to us. And part of the job is to find a balance with the gray in between, in which they can be caring but also effective. They can be firm and angry when that's appropriate, but turn that energy into engagement and motive change. Families and patients need a recipe for treatment. They don't often get that from us. What is it you guys do in substance use treatment? Around and circles and hold hands and talk about your feeling. It's all mysterious. What are the rules? What are the expectations? What are the responsibilities? Who has what job? And we don't even do a very good job, I think, in role induction for patients, never mind families. Families, not surprisingly, if you think about it, really do have core competence. And they have natural leverage in terms of being able to persuade towards motivation and behavior change. There are some families, for sure, that are so toxic that there's no possibility. There are families that are injuring the person and abusing. Okay, right. So those are circumstances, rare circumstances, I would offer, in which we do want to separate people from dangerous families. But most families have something good to offer, and we ought to be trying to access that. The notion that autonomy of a young person or autonomy of an older person in order to gain their own internalized self-efficacy for change versus empower family, that those are incompatible, I think is wrong. I think those things are incompatible. You can have your cake and eat it too. It's just how do you work on the recipe to get that? And then the other thing is that this focus on family involvement helps mobilize families to do better at the things that we want families to do anyway, never mind substance use disorder. In the example of OUD that we'll be talking about later, MOUD, medicines for opioid use disorder, are enormously beneficial, but they're not curative. And whether it's your kid or your partner, you still have to have a relationship with that person to make things go. And so how can we help that go better, since it's going to happen whether we have anything to say about it or not? We might as well have something to say about it, say something good or do something good. I want to make just a plug for the prevention angle here. We'll talk mostly about treatment today, but I think it's important, especially when we're talking about young people, to think about how families have an enormous role in prevention. And I like to think about addiction broadly as a developmental disorder of pediatric onset. And I say that because most onset is in the second decade of life during the teenage years, with known peak prevalence for all substances towards the end of the second decade and beginning of the third decade of life. And although there's plenty of people on throughout the lifespan and in later years that are using, when did they all start, right? So this is a problem of younger people in terms of initiation and progression to loss of control, and that makes it a problem of families and parents. When we think about the current crisis of OUD, which is on everybody's mind, the current crisis tends to minimize in the public eye the other things that are going on. Remember, the vast majority of youth who initiate opioids and then go on to lose control and have OUD have had problems with other non-opioid substances first. Earlier onset's associated with worse outcomes. Earlier intervention is associated with better outcomes. So we want to think, I think anyway, conceptually, of opioid addiction as an advanced stage in the progression of a core illness, that is SUD writ large, a more malignant, more advanced stage, but it starts with non-opioid substance use prior to opioid initiation. For young people, typically that's cannabis, alcohol, nicotine, etc. And so intervening earlier for young people in non-opioid substance use and then non-opioid substance use disorder is in itself prevention for OUD. And the scope of today's conversation, that means working with families to not make traditional excuses. Oh, we did it when we were young and we didn't die. Oh, it's no big deal. What's weed, right? It's not really a drug. I'd rather learn to drink with me where they can see by example responsible use rather than be on the street, etc. And as you guys know, again, outside the scope for today, early initiation is associated with outcomes. All of those myths are exactly that, myths, and very important angle of family engagement for prevention. And this is the kind of data that many of you will be familiar with, but most families, and so this is a kind of perspective on that prevention, which is to look at this particular data from the National Survey on Household Drug Use, looks at the incidence of development of a use disorder here for cannabis and alcohol in these two age groups, adolescents and young adults, as a function of time since initiation. And so a number of important points. One, that there are substantial rates of use disorder in youth, both for adolescents and young adults, soon after initiation for both alcohol and cannabis. We could show the same thing for other substances, but I want to focus on these early initiation substances that people tend to dismiss, unfortunately. And so here you have the time points from under 1 year to over 3 years. And you can see that within 3 years, there are these considerable development of use disorder. And early initiation, as we know, confers greater risk. Here, when we look at the 1 year point, the cannabis use disorder progression rate within 1 year for adolescents is about 11% versus 6.5% adults, and at 20% versus 11%. So very substantial numbers of young people are developing use disorders very quickly after initiation. And interesting to see, right, that for cannabis use risk is higher than the alcohol risk. So, this kind of saw that cannabis is no big deal. That's just not true. All right, so we've established, I hope, some barriers, the rationale for why it would be productive, perhaps, to work with families. How do we do it? What are some of the basics? Well, one of the things to think about is to come to this issue of both confidentiality and autonomy. And I think it's important to really hone in on what can be a conceptual barrier for some clinicians who understandably say, well, this is the patient's treatment. How do I broaden that to other stakeholders? This is not the family's treatment. What's their stake here? What if the patient says no? What if the patient doesn't see them as a positive force? What is my responsibility? How am I to ethically navigate this? So the question is, we have an obligation to serve the patient, but what does it mean in context of severe SUD? Serving the patient might need to be broadened to the explicitly and initially stated wants of the patient. The patient is often not an autonomous, mature, self-directed agent, right? Either because of age or intoxication and the impairment of use, or both. Sometimes what the patient needs is different than what they want in the moment. Now, that's old news, but explicit, because the patient may not know it yet, but involving the family will likely help. And rather than think of it as a dichotomy between the patient and the family, we should be thinking about synergizing rather than antagonizing, and that the patient's immediate stated reservations are not the final word, and that we want to get to yes, and we want to finesse the question of how them to be persuaded, how to get them to agree, because based on our experience, we have the sense that they might be making a mistake in their initial knee-jerk reaction to say, no way. So up against a confidentiality barrier and wanting to involve families, what's the best way of approaching that? And the two extremes that I would reject are immediately assuming that we should be following rigid limitations on disclosure, not say a word, none of their business. Patient says they don't want us to talk to the family. I guess we're never going to try to talk to the family. Open and shut, case closed. Or on the other hand, also, I think not the right approach, is to sneak behind the patient's back and make unilateral decision to surreptitiously make disclosures without the patient knowing and against the patient's expressed desire. I don't think that's the right approach either. I think the right approach is getting to yes. And the same way that we sometimes, say to a 6-year-old that doesn't want to put their socks in, well, you can choose red socks or you can choose green socks, but you can't choose no socks. So we're going to get to yes. The assumption is that we expect you to give us consent. We expect to normalize this as part of our treatment approach, but it doesn't have to be an emergency. It doesn't have to be today. We want your cooperation. That's going to go better. How do we get to yes? So just to expand that a little bit, to look at some of those alternatives, what's the way to try to do communication with the family? Patient initially thinking about They're distaste for that. You can't talk to my family. They're just going to be punitive. They don't understand. They drive me crazy. Can't. Well, should we just say, okay? I think not. Should we say, watch me? I'm going to do it anyway. As I said, I don't think that's the right way to go either. What about let's talk to them together, right? Let's bring people together and see how we can negotiate this, the rules of the road, and allowable communication. And by the way, they're going to call. Want me to say when they call. Got to say something. So help coach me and teach me what the appropriate messages are, what's on limits, what's off limits, and how we can make that go better. So how do you do that? One of the things you do is you normalize it. This is just a standard procedure in treatment. This is what we do. This is how we do it. This is why we do it. We're not looking to get you in trouble. It just helps things go better. As I say, teach me in a way that's going to be helpful to you. Let's invite them in and see what happens. We can always throw them out again, right? If you say yes now, you can say no later. Give it a try. What's the worst that could happen? Don't you want their help? They have resources. It was likely by, at least in part, their doing and their influence that you got here in the first place. How can we think of, despite their limitations, despite their being cranky and naggy and all those things that you say, at the core, they can help. How can we shape that? By the way, maybe I can run interference for you. And by the way, that gets you a lot of credibility points when you can sit in front of the family and show the patient that you're able to get them to back off. I can get them to nag less because I convey a certain authority. I can get them to take it down a notch and stop yelling at you. I can get them to perhaps be less critical and try a more positive approach. And if you can pull off that, even 5%, you're a hero and you have considerable credibility engagement. And by the way, they're going to find out anyway. It's almost impossible to have secrets. This example and this example and this example is that it always outs. So won't you be better off if it comes from you directly rather than getting busted later for keeping a secret? And that way you can spin it your way and get the advantage of demonstrating your new motivation, your new attitude, and win some family. Now, the families don't know how to do this any more than the patients know how to do this. And the families need a lot of teaching and a lot of coaching and a lot of encouragement. We spent a lot of time talking about picking your battles. You can't have everything. And just as an illustration of that, I can't tell you how in working with the parents of adolescents and young adults with life-threatening OUD, I get, why can't you get him to clean his room? And we're going to spend the whole session talking about he won't make his bed. Wait a minute. Are we going to talk about injection fentanyl use or bed? It's up to you, but you can't have different priorities. Pick one. Which one is it going to be? It's a bit of an exaggeration, much. The families don't really know their leverage points. Remember, they're up to their ears in alligators in crisis. They don't know how to turn. They feel like they've done everything. And they almost always have more juice than they know, more leverage points. And so getting them to see that. What do you mean I should give them rewards? I'm not rich. I don't have thousands of dollars to throw around. Not saying that. What is it that's already happening in your family, the kinds of transactions that are valued by your family and your loved one? Do those things anyway. Is it prices? Is it cigarette money? Is it treats, family meals, taking them out to restaurants, family attention and activities, playing ball? Whatever it is that you do, what about linking those as they are within your resources to treatment progress and shaping behavior towards the things that we as a group are going to prioritize and delineate? Keep your eyes on the prize, right? We're playing the long game here. This is a marathon. This is not a sprint. I'm good, but I'm not going to be able to cure your family member by tonight. So We got to just keep at it, one step at a time, 3 steps forward, 2 steps. And they're so crisis driven and emergent in their thinking that that's a very hard thing for them to digest. Rewards will work better. That's counterintuitive. Uh, I'm not going to tolerate this. I'm going to come down on him like a ton of bricks. I'm going to cut his head off. Maybe, but how's that for you? And maybe a different approach would work better. For parents before, teaching them that compromising to earn family points, husband, wife points, mom points, will be worth their while, because in the long run, garnering the resources and convincing the family that they're making progress in motivation and in other treatment goals will make things go better, and they'll get the things that they're dissatisfied that they're not getting now. And aren't you tired of battling? And I use this phrase all the time. Well, I know that's the way you've been doing it, and I know that's what you believe, but how's that working for you? And if it's not working, can we look at modifying that? Families can be partners. And so the notion of being able to structure services in a way that we can meet with the families with the patient, and also meet with the families separately, because they're going to need extra coaching. And sometimes you can say things to them alone that you wouldn't necessarily say together. And that's very important. That's not trivial, though, because if we think about service delivery is commonly organized in the specialty SUD treatment arena. We're doing a lot of group treatment. We're doing a lot of individual sessions. Where do the families fit in? How do you organize that? One way of beginning is by just asking the patient things about what they think the family knows and doesn't know, what they think the family's attitude is. What does your spouse know about your cocaine use? What does your mom know about the medicines that we sometimes use for the treatment of OUD? And figuring out what gaps are, give you nice targets for intervention, and you can advise them about strategies. And when you frame this as part of the standard procedure, the standard of care, you can insist on releases. You can say, this is what we do. We want you to sign a release for us to talk to your parents, just talk to your other, all that kind of stuff. We can communicate about the test results, but let's negotiate about how that's going to go and who's going to know. And we can have joint meetings. And both the family and the patients will be surprisingly, I think, interested in doing that. And at first they might think it's strange if they haven't seen it before, but it's really quite compelling, encouraging, and reinforcing, I think. Here's an example of a way that you see some progress with a family member, a 38-year-old man who has OUD. This is his second time through an inpatient course of care, including withdrawal management. The treatment significant other is his live-in romantic partner. They've been together for 10 years, have a household together, 2 children together. And as she comes in to talk at the team's invitation, she's at her wit's end. I'm done with helping him. I'm too tired of his lies. I'm going to throw him out of the house, cut him off financially, get a family lawyer, and he won't be able to see the children because it's just more than I can handle anymore. I've been following his steps on the cell phone where I'm tracking him, and every time he's going through a particular place where I know it's bad for him and he cops, we have a fight about that. And turning that kind of energy, de-escalating, taking it down a notch, and into a plan for action, in which rather than saying, no, 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 I won't do this, you can't do this, I'm done, say, I want to go forward, but only under these circumstances. Instead of no, it's but. So it's not that you can't come home, but it's that you can come home if. It's you can come home when. So in this particular case, started on extended release buprenorphine during the course of inpatient treatment. It took a stance that that was going to be the red line, bottom line condition of coming back home. Things went well, but then later on in outpatient treatment, yeah, I didn't want to do it, but I didn't want that dumb shot. I agree, it was a good idea, and I haven't been using by the way, I've started back up with drinking. So you're not done, right? It's not that what you've achieved as a first negotiation is curative. It's an ongoing process. Well, now what are we going to do about the drinking, and how do we kind of shape those leverage points? And again, the family has juice, not only more juice than they know, but oftentimes more juice than we have, because they have special powers of persuasion and natural authority based on their long-standing relationships and caring and connection that we couldn't have as white-coated professionals. We've been calling this kind of approach to including families a family framework, and it has these kind of elements that I've been talking about. But just to make them explicit, one is family education. And to remind you, it's amazing, or maybe it shouldn't be amazing, what families don't actually know about SUD, right? What are its sustaining factors? How do we treat it? For OUD or alcohol use disorder or nicotine use disorder, where we have good medicines, what are the medicines? How do they work? How do you take them? What are the expectations for ongoing treatment? What do you mean he's not fixed? I thought if he spent 28 days in rehab, he'd come out and he'd be all shiny new and finished. No, it doesn't exactly work like that. Here's the for ongoing chronic care. All of those kinds of things are so important because families don't know what they don't know. A three-way treatment plan, which is a collaborative discussion between the patient, in this case a youth, but could be an adult as well, the family, and the clinician. Everybody on Zoom, or during the pandemic, everybody's on Zoom, same idea. The notion of we're going to get together and we're going to talk this out up front and agree what works in your family. What are going to be the rules of engagement on communication? How will your family know about how things are going for you? How do you want your mom to learn about your attendance, about your treatment progress or not, about your results or not, about your getting medicines when you're supposed to get them or not? Family, what will you do to help support that? What do you mean, what are we going to do about the problem? He's the one who's got, well, yes, he's got to do those things, but wouldn't it be cool if you could help? How can you get the ball for the field, to use a stupid sports metaphor? How do you support attendance? What will you do if you learn that that isn't going well? What will you do if the medicine doesn't get in him or her? What will you do if there's a lapse? And one thing in particular that you'll notice for OUD especially is that much of the idea is focused on medication adherence. Now, unfortunately, we don't have efficacious medicines as clearly for other non-opioid use substances, cannabis, stimulants, psychedelics, etc. But at least in the case of OUD, there's such an enormous contribution to the variance size of these MOUD tools that really, really helpful. It's also really helpful because it's concrete and understood. And as I said before, lots of what we do in SUD specialty treatment is a bit mysterious. But one thing that most families know about is what it's like to utilize medical services. You take your kid to the doctor, and the doctor prescribes some medicines and gives you a recipe, a prescription for an intervention. And that's kind of a familiar way of working through problems. And every mom, right, has had the experience, cranky, truculent, febrile 5-year-old with an earache that didn't want to take the pink medicine. Now, it's a lot different being able to hold a 5-year-old in a basket hold and squirt a syringe of pink medicine in their mouth than to deal with 200-pound 25-year-old who doesn't want to take his buprenorphine. But the concept is there. We got an uncooperative, irritable, not person who's not themselves, who can't see their way out. They don't know how to utilize medical services. We can help with that. And drawing on that kind of familiar utilization pattern, I think here has proven to be very impactful. And then the most important thing is backup plan. Everybody's at a moment, a nanosecond perhaps, of high motivation. Everybody's saying, this is really great. We're going to try to make this stick. We're very pleased with this interesting approach of working together. Thank goodness we're done. What? No, you're not done. God forbid it takes a left turn. It doesn't go well. What's the backup plan? And I'm hoping we never need to invoke this, but just in case, backup plan and a backup to the backup plan. What if there's trouble? How do you want us to call the cavalry when we think you're in trouble and we need your loved one? If in your family the patient gets in trouble, how would your family manage re-upping treatment, supporting treatment goals, getting them back up if they stumble and skin their knee? And that sets the expectation a little bit. You don't like to say it. We don't like to say that relapse is inevitable, but just in case, we're not going to quit. Again, this is a marathon, and so we want to plan now before everybody's at each other's, throats yelling about that's you've lied, oh, you're trying to bust me. Before we're there again, let's get it all written down now and put it on paper and everybody sign it. Not that it's a legally binding document, but that ritual helps with form. It gives you a document that you can go back to 2 months later. Well, look, we met, remember, 2 months ago, and we wrote down on the family agreement, you said that you were going to do this, and if that happened, you're going to do this. So I guess we should do that, right? But those kinds of things, I think, are very helpful. At a first session, as I said, normalizing this, getting the releases up front, and thinking about the rescue plan. This is not an effective family intervention, right? Gandalf saying to the Balrog, for those of you who are nerdy Lord of the Rings fans, thou shalt not, that tends not to work, right? So again, working on the negotiation, working on getting to yes, on setting these expectations in a dynamic way, and the hard work of working at it. As I said, families will initially balk about this idea of rewards and incentives. And what we're trying to do here is essentially take the principles of contingency management or motivational incentives, one of our strongest behavioral interventions with the highest effect size of almost anything we do in SUD treatment, and in a less formal way, apply that to the home life and get members to use the principles of rewards and incentives. And if they have resources, that's great. If they've got cash, sure, that's great. But most people don't. So mostly it's thinking about the kind of resources that the family, as I said, might bring to bear and how to attach those to particular goals. If you don't go to treatment, we'll have to stop paying for your cell phone. If you do go to treatment and come out and have a certain amount of progress and are looking spruced up and good, then you can move back into the house. Anyway, these issues need to be negotiated and made concrete. And the family, you can't just say, here's some examples, go home and do it. I'm sure you'll figure it. It's a heavy lift of working it through, being concrete. When you said it's $5, let's write down that it's $5. If you said that it's $5, if such and such happens, let's write down such and such. The usual impetus will be that we'll give them a big prize after they've been sober for 10 years. Well, that's not how operant conditioning works. It's frequent checks and monitoring. It's frequent rewards. It's bite-sized, accomplishable goals. Catch them being good. All those things that you guys know about, but that the families don't. Okay, so those are some of the basics. And now I want to take some of those concepts and show you an example of a particular intervention that we've been working on now for several years. We call it the Youth Opioid Recovery Support Intervention. And it's in particular treatment for OUD in young adults, incorporating some of these elements, including especially family engagement. And you may know that MOUD is certainly first-line treatment for this target population with OUD. The evidence is not maybe as broad and as strong as it is for older adults, but it's very clear. Here is some data reminding us of the important impact of the use of MOUD on retention in young people. On the left is some Medicaid claims data looking at the receipt of medication to non-medication treatment and showing a substantial improvement in retention over the course of a year. And on the right is similar combined claims data, both Medicaid and commercial data from another system, looking at across both adolescents, young adults, and older adults, the remarkable step up in ongoing retention, this is at 6 months, in those that receive psychosocial treatment only versus receiving buprenorphine. So big impact. And if only it were that simple, right? So what MOUD does, then all we need to do is get more people to MOUD treatment, write more prescriptions for buprenorphine or other MOUD, and we can all go home and sing hallelujah, right? Well, not so fast, right? The idea is that still outcomes for young people are not as good as for older adults, and that uptake is poor. But not only is uptake poor, retention is poor, and dropout is alarmingly high. And I want to use this little vignette as an illustration of some of the developmental vulnerability issues that we see all the time in young adult OUD treatment. Got a 22-year-old young man, onset cannabis at age 14, illustrating the point that usually people who get into with OUD have had the onset of loss of control over a previous non-opioid substance, in this case cannabis, earlier, onset of opioids at 17, progressing to daily use with withdrawal within 8 months, by 18, and injection heroin 6 months later. Obviously in Baltimore, that means not just injection heroin, but injection fentanyl. So it's quite severe with very high risk of morbidity and mortality. And that illustrates, if you will, the very compressed or condensed time course with rapid progression that opioids confer. Very different, perhaps, than if we were talking about alcohol use disorder, where you would not expect progression within 18 months from a first beer to half a handle of vodka every morning. So opioids have that special malignant toxicity that we were talking about. And this young man has had several episodes of residential treatment with withdrawal. He's left prematurely. He's graduated from one, but didn't go to the prescribed continuing care. He did initiate one outpatient course of buprenorphine treatment, but it wasn't exactly a success poster for buprenorphine treatment. Met the doctor who said opioid use disorder, here's a month's supply of buprenorphine and 4 refills and have a nice life. And that didn't go so well. He didn't take it all. He sold some of it. He continued to use heroin on top of it. So again, not exactly an example of the world's most successful buprenorphine treatment. And he comes again in crisis to you, to me, to outpatient treatment, to residential treatment, whatever. In this case, it was residential treatment. And he says, you know, I may not have done this right before, but I'm really in a pinch, doc. And he's in 7 different kind of crises, the way people who often present to treatment are. Kicked out of his home by his parents, broken up with his girlfriend, in trouble with his probation officer, fired from his job, whatever it is, and probably all of those things. And he says, you know, this time I really mean it. I'll do whatever you say. I'll stand upside down in the rain naked, doc, if that's what you want me to do. But I'm kind of in a hurry. And I'm thinking, can we get on with this? And can I be out of here, you know, by Friday? Oh, why do you need to be out by Friday? You have a job to get to on Monday morning? No. Do you have kids at home that require your care? No, it's not exactly that. It's that on Saturday night that's really cool and I need to get to. Oh, and by the way, did I tell you that I have this terrible anxiety problem and nothing works except for one thing, and you guys can guess that that's Xanax. And no, you can't talk to my Xanax doctor. And no, you can't talk with my mom. But other than that, I'm an open book, doc. Let's get started and hurry it up, will you? And I don't mean to trivialize anybody's suffering. This is obviously a young man at considerable risk. But I just use that to illustrate the puzzle, if you will, of what are we going to do here and how do we proceed to make inroads to engaging him And can we use a family engagement strategy to help make things go better, to help overcome some of the developmental vulnerabilities that are implicit in this target population? And those development will include all the things you know about. They're invincible, immortal, this doesn't apply to them, aliens of consequences, and they've had fewer consequences than older adults because there's fewer road miles on them. And there's an amazingly strong salience of the burdens of treatment. There's a million things I'd rather be doing, Doc, than being in treatment. And if you're telling me I got to come back to outpatient treatment afterwards, forget about it. This is just some data that reinforces the notion of poorer outcome in young adults than older adults. On the left is a secondary analysis of the famous XBOT study that you guys know. XBOT was a randomized trial of buprenorphine versus extended release naltrexone over 6 months. And we reanalyzed that data comparing the older adults in the trial versus the younger adults in the trial. We've collapsed both treatments, washing that out, but making the point that although the young adults have non-relapse rates at 6 months of 34%, glass half full, glass half empty. The glass half full is that many of them do respond to MOUD, about a third of them without relapse at 6 months. That means 2/3 of them have relapsed. And if you compare it to how adults over 26 have done, it's considerably worse. And on the right is Medicaid claims data information at retention rates over 6 months for these 3 age groups, with adolescents doing most poorly, young adults doing more poorly than older adults. So for all of the reasons that we talked about, we're not doing as good a job with young adults with OUD. So what are we going to do about it? Aspirationally, if we have high motivation, we might be able to retain them. And this is in a specialty outpatient IOP treatment program in which we had 40% retention for a mixed group of extended release naltrexone and buprenorphine patients, young adults with OUD. But these are among those who have already initiated intensive outpatient treatment. They've overcome withdrawal, they're out of residential treatment, they've signed on, they know what's coming, they're on medicines, and they've agreed that they're going to be involved in this. And so 40% retention at 6 months, although not as good as older adult, is still pretty good. But if you go upstream, you look at a broad swath of youth presenting to crisis-driven episodes of residential treatment, all comers, and you say, all right, we're going to try to get you started on medicines because we think that's the standard of care. As it turns out, although a third of them took extended release naltrexone and a third of them took buprenorphine, more than a third of them said, no, thank you, I don't want your stinking meds. And then when they left residential treatment, in spite those that were started on either naltrexone or buprenorphine, in spite of saying, yes, I'm in, yes, I want to do this, yes, I'll accept a referral to continuing care treatment in the community, including medication, the results were relatively dismal, with 6-month mean extended release naltrexone doses of only 1.3 out of 6, only 2% getting all 6 doses. And it wasn't really better for buprenorphine, in which only 60 days out of the 180 days in the follow-up period were buprenorphine days. So in general, community treatment as usual for all comers, that is upstream in the opioid cascade of care, we're not doing so well. So that's why we thought, well, there's a lot of room for improvement, and that's the impetus for the development of this yours intervention. And the 4 components of the yours intervention are assertive outreach, that is, not waiting for people to come to us, but we're texting them and we're calling them and we're reminding them and we're thinking of ourselves as used car salesmen and at them and pestering them in only the nicest way, though, right? Family involvement in the way that we've been talking about, delivery of medication, so bringing extended release MOUD to patients' homes. When we first began this, the only extended release injectable available was extended release naltrexone. We've since expanded that extended release buprenorphine since that's become available. And then adding contingency management, providing motivational incentives, that is, paying them for receipt of medication. So here's an example of how family helps us with making things go for this. You got a 21-year-old young man with injection fentanyl, heroin use. He's had several inpatient residential admissions, including detoxification, over the past year and a half. And on each of those occasions, he did agree and received a first dose of extended release naltrexone, get to ongoing community treatment, but never shows up once for any further subsequent outpatient treatment, never gets a second dose, and always relapses, and hence has been back again and again. Here he is again. This time he was enrolled in our pilot study for the Yours intervention, and with his grandmother. Grandmother is the treatment significant other who we've involved in, and the mobile team, the nurse, the therapist, shows up at the house ready to give him his second dose. By the way, he hasn't been coming to IOP like he said he would. He hasn't been coming to group, but the intervention is very focused on getting the medicine into them, because that's the deliverable and the biggest contribution to the variance of relapse. Shows up at the house, we're ready to give him the second dose, and he's says, you know what, I don't need the medicine. And whether he doesn't want the medicine, he's fixed and can do well without the medicine, or because he's made a decision that he wants the option to use heroin, I don't know. But it doesn't matter, because we know that if he doesn't get the medicine, he's in trouble, whatever his immediate intentions are, as previous history of repeated examples. But grandma, who is now in the picture and hadn't been in the picture previously as a treatment partner, can now exert her natural leverage, her natural influence, because of her relationship, because of the authority of her caretaking. She's got juice that I don't have, that the therapist doesn't have. And grandma says, no is not an option. You're getting the shot. Well, done deal. And this guy does very well and completes the intervention, getting all 6 doses. Now, it doesn't always go this is the poster child, but that's the aspirational idea. And I just want to show you a few examples of some of our 3-way texting communications. One of the ways that we do the assertive outreach and involve the families in a way that's developmentally appropriate for young adults. Answer the phone. They don't read smoke signals. They don't come in and talk to you. Will respond to texts. And so putting a family member and a therapist and the patient, young adult patient, on the same text is a nice way of doing open communication and transparency, treatment goals, both positive and negative. So one of the things that promotes engagement is just communication and monitoring. Hey, Ms. Blank, it's the mom, just want to let you know that Brittany got her shot. Great, thank you so much. Hey, Dave, in this case, it's the dad. Already surmised this since you were visiting, but we just want to let you know that Jeremy is now back on the shot. So this is a young person who dropped out, and then we re-engaged. That's great news. Thanks. I think he needs some mental health support, et cetera, et cetera. Here's an example of how, and I was really to learn about the power of texting as a mini therapeutic intervention, right? I'm an old guy. What do I know about texting? But to see the ability to, with powerful therapeutic content in this very kind of compressed communication modality, doesn't always work, but it can be quite powerful. The kids texting, hey, I'm getting kicked out because you told my mom I didn't leave a urine. So yeah, she's going to, and I'm going to have to stop. Or you can come leave a urine. I couldn't pee. What was I supposed to do? Wait for 2 hours until I could? I'm bleeping homeless now. I'm going to have to go into the city and live in an abandoned building. I'm still here. Come leave a urine. Don't use this as an excuse to relapse. Thanks for everything. Goodbye, cruel world. All right, I'm coming up to leave a urine, et cetera, et cetera. And then before you know it, and am I getting the shot this Friday? Yes. Is that timing okay? Et cetera. And so there's a lot that can happen. And this is in front of both the parent, the kid, and the therapist as part of a way of communicating over treatment progress. Here's an example of this question of the compatibility between family empowerment and young adult. I'd be interested to hear, what you think about this. The team, the nurse and the therapist, come to the house. They're going to give this young woman a dose of injectable medication. Patient says to the mom, "Mom, you can't be in here while I'm getting ew. I'm a grown up. Leave me alone. I'm not going to take my pants down in front of you." And that makes sense to the nurse and the therapist who are thinking about this as a confidential medical procedure. "Excuse me, ma'am, I think it's best if we provide her privacy for the injection. Could you excuse us?" And the mom says, "Are you kidding me? Of course I'm staying in here. I'm not leaving this room till I see that medicine go in you." And I'm not necessarily endorsing that that's what the mother ought to do. And is that overbearing or over intrusive, or is it not? The devil is in the details of these individuals, but I use it as an illustration of one way in which a parent can be empowered to use their additional leverage for monitoring, for achieving a treatment goal in a way that works in their family. And so this is, one among many different kinds of ways in which a parent can learn to be part of the team. Now, maybe over time, the mother can be from doing this again. "Hey, that was embarrassing to the kid," in a private conversation. "Next time, now that you know that she's doing a little better, could you excuse yourself graciously? And we'll give you a wink on the way out to assure you that, in fact, the medicine did go in her, but you don't necessarily have to be in there," et cetera, et cetera. Here's an example of keep your eye on the prize. "Hey, Team Roger," that's how we sometimes address the family because it's Roger's parents. "Missed y'all today. We haven't seen Roger in 3 weeks, and I want to make sure that we're still on for our appointment to get him his medicine on Thursday." "Oh, wait, Wednesday. I thought it was Thursday. Oh, wait, which is the day?" And there's some confusion. And then Roger weighs in and is flipping everybody the bird. And the idea is, we're not going to take the bait. We're not going to get into a battle with Roger. And hopefully that's modeling behavior and attitude for the parent, who typically is a person who would have then started yelling, "Don't you dare roll your eyes at me, young man. No, we're not doing that. All we care about is getting the shot in, and the rest is details. We'll talk about cleaning his room next week. This week, let's just get the shot in." Don't take no for an answer. "Can you please stop calling my mother? I'm done. I don't want no more shots." "Can you give us a call? Thanks for sticking with us. We'll see you tomorrow around 7:30 for the shot." The idea is we're just going to press on relentlessly in as long as we can, trying to execute action where the consummation and the important goal is getting the medicine in. Just to think about how you might do this. You've got a young woman who's on an extended release medication, either buprenorphine or naltrexone, either way, doesn't matter, patient choice. But she's late for her dose. She's living at home. She's had recent sporadic opioid use, towards the end of the dosing cycle. Some people will try to overcome the blockade, especially now that it's late. She's starting to dabble. The question for the clinical team and for the family and for the patient is, how close are we to the precipice of a lapses turning into a full relapse? What do we do? We're at a juncture. How would we proceed with family communication? And I'll just look at these options. I don't know which one is right, but them are on the table in this treatment intervention model in terms of thinking about how to get her back into care and get the dose into her. Is it immediately to call the parents, call the cavalry, and sound the alarm? Well, that's maybe a last resort. Maybe we don't need to do that. If we needed to, maybe that would be the thing to do. We would do it behind her back. We wouldn't want to do it surreptitiously. We'd want to invite her to the extent we could to be part of that discussion, But if we can't do that, the table. Is it work with the patient to get the dose? Hurry up, let's get it in you. You're late, but let's go. But protect her confidentiality? Well, we wouldn't protect her confidentiality at all costs. We think that transparency is important, but if it helps her save face and helps us get the deal done, then maybe that's on the table. Is it to say, well, you've got one more chance, we need you to get the shot by tomorrow, Friday, whatever, or else we'll need to call your parents? Well, maybe that kind of leverage is helpful. Let's call the parents together. Come on, you're in the office now or you're on Zoom together. Let's invite how we can make this happen. Maybe you get the dose and then we'll tell your parents together after you've gotten the dose so they hear as if you were in trouble, as if we're ratting you out, that you haven't done something. We'll call together from a position of strength and brag on you about how pro-recovery you're being, that despite the barriers and despite things maybe not going well for the past week, you're back on the bicycle, ready to go, on board, got your dose, rah, rah team. Or send a group text saying, hey, just want to let you know that so-and-so is past due. How are we going to make that happen ASAP? Again, the choice of strategy, is about the individual in the particular circumstances, but it's just useful to have a repertoire, a tool chest. And now I just want to conclude with showing you some of our preliminary outcome data. We started with a small randomized trial with 40 kids, half of them in the yours condition and half in treatment as usual. Young adults with opioid use disorder who were prescribed extended release naltrexone during an index episode of residential OU. Not every one of them actually got a first dose of extended release naltrexone, but most of them did. And the notion was they were either in the yours delivery intervention that we talked about, or given referrals to standard care and ongoing medical treatment with extended release naltrexone, and follow for 6 months. And here you can see the difference in dose, right? And for that study, it was 4.3 doses received in the yours condition versus less than 1 in the usual care condition. And in the yours condition, 44% received all 6 prescribed doses and 0% in TAU. On the right is a second study we did after extended release buprenorphine was available. We did an uncontrolled open label single arm study. We had the choice of extended release naltrexone or extended release buprenorphine. Was that we're agnostic as to what medicine they take. Both have known efficaciousness. And so the idea is what works for you, pick one. That broadens our scope. In general, buprenorphine has more appeal in most populations than naltrexone, probably by at least 2 to 3, but whatever. And then we compared it to the treatment as usual comparator condition from study 1. And you can see the results are about the same. With these 22, it was about 3.7 average doses in 6 months compared to under 1 again. And here are the relapse survival rates for both of those. I should say the non-relapse survival rates, defining relapse not as any opioid use, but defining it as greater than 10 days per month, some kind of clinically meaningful threshold of return to regular opioid use. And so you can see over 6 months, glass half full, the yours condition does much better than the TAU condition, with about 60% relapse or 40% non-relapse versus 95% relapse or percent non-relapse. So it's much better, glass half full, than TAU. Although if 60% are, if 40% are non-relapse, 60% are relapsing, so glass half empty, there's still considerable room for improvement. And on the right, again, is the second study in which there was a patient choice of either buprenorphine or naltrexone. And the results, again, are very similar. One of the things that's, as I say, very remarkable is how poorly TAU in this population. What we're up to now is refining the intervention, learning new kinds of ways to tweak it, and preparing for a larger randomized trial in which we hope to have over 100 young people enroll starting later in the fall. We've had several test cycles of iterative enhancement. The first test cycle included some COVID adaptations because nobody predicted that the pandemic was coming, but we used it somewhat to our advantage and made, I think, lemonade. We began using telehealth, as all of us have, and we're concerned about the infectious disease transmission rates in house, where there were family members and going, and we didn't know who was vulnerable or who might be infected. We switched to mobile van delivery. And so here's Nurse Stanley giving a dose of Sublocade in the back seat of the mobile van. And so that's been pretty successful. We've also tried using the mobile health app Reese, you might know about. We've started a parent peer-to-peer telehealth group, and we've introduced a periodic written feedback report card. So, stay tuned, results to see on which of those things we'll keep and which we won't. But the idea is, as I said before, there's plenty of room for improvement. So we're still looking for ways of making things better. Anyway, the conclusions that I just want to recap for a second, as I've shown you both the general approach that I would like to advocate for family and also the particular example of a family-based engagement for young adults with OUD, is that families, and I hope I've convinced you of this, are a rich and robust source of recovery support. Remember, the families will be around and involved with the patient a lot than we will. At some point, the patient will be involved with services with us, but the family, if they have positive engagement and the ability to keep things going, will have a longer shadow, a bigger footprint of influence. It's not easy. It requires flexibility on the part of clinicians, on the part of families, on the part of patients. It's a big lift, but it's not usually as big a lift as people think at the outset. It gets easier as you practice. The families, including the patient, usually fairly grateful. It's common that we hear things like, I didn't want you to talk to my family. It was going to be like busting me. At the time, I wanted to not have them find out. But, now in retrospect, it went really well. I'm so glad that you brought them in. It's really helped. I don't hear that every time, but that's mostly what we hear. And so to conclude, we just need to work harder to engage families. And I think it pays off. I think we have a few minutes for questions. I don't know whether you guys want to do this through or people unmute themselves and ask. I've included here some selected references. If you guys want to get the slides later, you can read in more detail to your heart's content. But are there questions? Are there points of discussion? I'll stop sharing and we'll get to the chat.
Thank you so much, Dr. Fishman. I really appreciate the talk. We have one question so far in the chat, and so it may be easiest just for people to put their questions in the chat, and then I'll read them out as we go. So the first question says, Dr. Fishman, can you talk a bit about involving children in the treatment of adult patients with substance use disorder? Do you do this, and with what ages?
Wow, what a cool question. I have not had experience with young children. So if you're talking about teenagers and addicted parents, it's a very intriguing idea. Haven't done that, but I've certainly done it with adult children of patients who have addictive disorders, and the model is very similar. That is, if it's a 20-something, a 30-something-year-old child of a 40, 50, 60-year-old person with an SUD, thinking about how to bring them in the team and manage the issues of communication and engagement and confidentiality, preserving and respecting the autonomy of an older person. And the developmental issues will be a little different, but of a similar theme. Not the issues of my parents can't tell me what to do, but I'm the grown-up, and how dare that young whippersnapper deign to tell me what to do. We've seen, you see these issues all the time when you're dealing with issues of aging, if you're treating cognitive impairment and dementia. These are delicate issues that we navigate every day in the world. And we're talking about how just applying those same concepts of artful negotiation and engagement could be applied in the case of SUD. So yes, I've done that. But I'd be interested, did you have something in mind? Were you talking about younger children and thinking about how that might go? It's not something I've done. I don't
Thanks,
know if
Dr. Fishman. That was my question.
Unmuted and talk more about that.
This is Danae Draco. That was my question. I haven't done it. I've just been thinking about patients I have with younger kids and like other, kids whose parents have been, children, patients I've had with parents with substance use disorders. And I just, just seems like there's a lot of area of like therapy that could be useful there that, kids really struggle when their parents are using, and parents aren't always seem to be as aware of the impact that has on their kids as maybe.
No, one thing I will say is that there's a rich practice, experience, and literature on using parenting as an opportunity for intervention, right? We do this with pregnant and postpartum women's programs, but we can do it across the lifespan. And for both men and women, the notion that that moment of either becoming a parent or having enduring parenting responsibilities is an opportunity to get a think about their broad social role and to think about the importance of preserving connection and the importance of thinking about the world outside themselves. And it's an opportunity in which we emphasize how pro-social an activity parenting is, and let's run with that, but also emphasizing how stressful parenting can be and all its potential for being a relapse sustainer or trigger that needs to be managed. But I do think it's important that there's lots of things that we can do around parenting and around family life for enriching interventions.
Thank you.
Yeah. Here's a question about the confidentiality issue. An 18-year-old patient sends a text like, "Don't call my mom anymore." It's a sticky wicket for sure. So again, trying to get to yes, how can we overcome that resistance, thinking it as an initial overreactive, impulsive decision that maybe we can get beyond, but we want to be respectful. We're not going to unilaterally contradict that person unless we think that there's a big imminent dangerousness issue. I mean, that's an individual clinical judgment call. What threshold of imminent clinical harm will you invoke in a particular case to say, I have a duty to warn, I have a life to save? Each case is somewhat different. But in general, trying to avoid that unilateral surreptitious contradiction of a person's wish and see about getting them back on board. Another trick is that if we're not allowed to talk to a parent or a family member, we can convey that in a message to that family member that says, your loved one has revoked their permission for me to talk to you. That's very clear message. And we talk about that at the outset when we set the treatment. If you ever get a phone call from me that says, I'm not allowed to talk to you anymore, let me tell you what happens. You should run, not walk, to intervene. So again, there's ways of handling that can finesse the issue, but it does happen. It happens surprisingly infrequently that they flatly say, I'm done, leave me alone, don't you dare, I'm a lawyer up on you. Rarely does it get to that, but it does occasionally, but surprisingly rarely. And when it does happen, again, it's the end around, not the up the middle, you must. What else?
I asked a question. Is there a difference in how inpatient rehab looks for adolescents as opposed to adults? Other than like the smoke breaks, probably.
It does. Young people probably need more monitoring and supervision on the one hand than adults. And I'll give you one maybe silly example, but it's practically important. I'm proud of access to tobacco rehab in general, right? We should be trying to have tobacco-free services. Are pretty insistent. It's not against the law, and they want their smoke breaks, but it is against the law for adults. So that's just a kind of a quirky, weird monitoring issue, but also the sense that minors will need more supervision on the one hand. On the other hand, they will be more likely to get into trouble with trivial rule infractions. This is an issue, for example, we've had an early foray into trying to learn about recovery residence services at young people, because they often don't do well in the general population of recovery houses with older adults. And it's in relationship to these developmental issues in both directions. On the one hand, the usual recovery house without supervision is not closely structured or monitored enough for most young adults. But on the other hand, rules are often too rigid for them, and they get thrown out for little stupid stuff, like I snuck my girlfriend into my room and I broke curfew, or I smoked a cigarette in the bathroom to duck around the rules, and so now I'm on. And so having to deal with a more developmentally targeted approach that might be able to work on both sides of that has been a puzzle. I'm not saying that we got it right, but we're trying to work on it.
Thank you. Another question was, do you have, are there situations when you don't recommend engaging a family in treatment?
Yeah, I do think there are rare situations in which family interactions are so demonstrably that you're thinking, boy, I got to get this person out of that family. And the obvious things that, that come to mind are violent abuse, domestic violence, sexual abuse, intergenerational substance use behaviors, like when the grandmother and the mother are injecting the young person and helping them, use substances together, those circumstances. But fortunately, those are the exception rather than the rule. But those would be examples in which you say, yeah, this is not a family that's going to help us any. Let's do something different. But I think there's positive influence to some extent in most families, and that's what I would make the default mode, absent evidence of that kind of malignant toxic effect.
I would think that presumably having grandma inject her grandson is relatively rare, but having intergenerational substance use is probably very not rare.
Good point.
And so how do you engage that family?
Yeah, looking at the gray, right? I've given you the example of the extreme horrible of facilitation of injection, but what about there's drinking in the household? What about there's cannabis in the household? What about cousin Charlie also has an OUD, and although he's doing better in his methadone treatment program, he's still sometimes bringing home some Percocet or some Xanax or some cocaine. So absolutely, the gray is worth looking at, and those are important examples. I don't have a perfect response to that. Each circumstance requires a balance of the pros and cons, but I do have a general approach that I usually try. I don't want to be so naive as to predict that it will always or does always work, but it's worth talking about. I call it my universal precautions approach. So you say to the family, listen, I don't mean to intrude, and I'm not making any judgment. I don't know whether you have a problem or you don't. I'm not saying you have a problem. You didn't come here to have you be evaluated. I know you're here for your family member. If you want evaluation, fine, we've got that. Happy to help you. No problem. But, listen, I know a lot of families where there is substance use in the house. People have a glass of wine with dinner. A lot of people think about abuse as no big deal. And I'm not saying that's what happens in your household. I just met you, and I'm not making any judgment. I'm sure that for you, it's not a problem, if it even happens, or your Uncle Charlie or your cousin Joe. But if we're trying to get one to cut down, you know, people and people do what you do more than they do what you say. So I know it's a big imposition. I know it's a lot to ask. I hate to even bring it up, but we often ask families to see if they can make substance-free households, at least for a little while. And I'm not asking you to do it forever. I know it's a lot to ask, and I shouldn't even bring it up. But do you think that would be possible? For a week, for a month, for 6 months, for as long as we can, not have a problem, but because we want to do our best to access and reduce example. And you can sometimes get traction with that and then not have to get into an argument about you have a problem, you don't have a problem.
Right. Thank you so much, Dr. Fishman. I think we're handing it over to somebody else on the committee to talk about the Rose Award. Would it be okay if people emailed you if they had any other questions?
Of course. I'm happy to talk with people and delighted that many people were watching. I hope that was helpful, and good luck with the rest of today's events.
Thanks so much.
Thank you, Dr. Fishman. I think that was wonderful. And I want to thank the CDD committee for doing a wonderful job with today's presentations. It is time, as Dr. Richardson mentioned, to give out some awards. Excuse me, I just want to mention a couple things about the Rose Memorial Award. It's named after Whitney Holland Rose, who was a second-year resident in our program when she was tragically killed in 2003. She was very active in her community. She had a spirited love for cultural diversity and showed a sense of compassion for all with whom she came in contact. It is in her honor that this award is given out to a psychiatry resident and to faculty who demonstrate tolerance and empathy towards their patients and others, and who is dedicated to serving their community and is interested in the promotion of cultural humility in psychiatry. I just mentioned we've had a wonderful Cultural Diversity Day, and due in large part to the extreme efforts of our two Cultural Diversity Day chair. Two of the awardees today are Dr. Joan Hahn and Dr. Rachel Dillinger for their efforts in putting this together. So if we could give Rachel and Joan applause. And we also actually have a third awardee in the residency class as well this year. And it goes to someone who I'm sure that no one's really surprised about, and that is Dr. Jamie Spitzer, who's been our first chief resident for diversity, equity, and inclusion this year, who's done a tremendous job in terms of helping the training office and actually the department in all of our efforts focused on diversity, equity, and inclusion. So let's give Jamie a round of applause as well. And I'd like to turn it over to Dr. Joan Hahn, who will give out the faculty award.
Thank you, Dr. Ehrenreich. I have to say the virtual Cultural Diversity Day was great, but I do miss seeing everyone in person. CDD was so much more fun when we were together. So on behalf of the CDD committee, I am extremely thrilled to introduce this year's faculty Rose Award recipient, and that is Dr. Anique Forrester. I do believe she is here in the room. The residents all wholeheartedly agree that Dr. Forrester, you continue to inspire us and you demonstrate empathy, cultural humility towards our patients and everyone else. And your dedication to the promotion of cultural humility in psychiatry, you invite us and you challenge us to ask these difficult but needed questions so we can become more culturally humble psychiatrists. So we thank you for teaching us and guiding us through your actions. Congratulations, Dr. Forrester. And now to end the day, I'm going to hand it over to Dr. Rachel Dillinger, my co-chair of the CDD committee, to wrap up the day. Actually, can Dr. Forrester say something, or Dr. Ehrenreich? Can I invite Dr. Forrester to?
Of course.
Okay, I wasn't sure because the residents didn't say it. Dr. Forrester.
Oh wait, something is glitchy on my computer. Can you all hear me?
We can hear you.
Okay. It looks like I'm still muted, but I want to say thank you so much for this award. I feel extremely honored that the residents think of me in such a positive light. That's sort of the essence of why I'm here and what drives my work as a faculty member. So I appreciate it, and I have a special fondness for CDD. It's an event that I participated in for the past several years. I think you all did a tremendous job today, and I understand the sort of logistical challenges of doing it virtually, but I think you all did a great job. And thank you again for this honor.
Okay, and now I will hand it over to Rachel. Sorry.
Thank you everyone so much for coming to the grand rounds and the rest of the day. I really appreciate all the speakers for taking time to prepare everything. I'm so happy, feel like I've learned a ton. Just so that we can put faces with the names, I would just like to formally thank the CDD committee. And I hope everybody has an excellent rest of their day.